Good morning, everybody. We've got a lot of new sites on this morning, and what I really like to do is to do some introductions, just to get everybody familiarized with each other. And we're thrilled to see new faces. We live for that, by the way. So this is great. So thank you for joining us. And I think we'll start with introductions here, and then we'll go around screen to screen. So to my right,
Carmela Thomas, registered dietitian and certified diabetes educator.
Evan Class, endocrinologist.
Veronica Brady, nurse practitioner, diabetes educator.
Okay, and then our support team.
Troy Jorgensen, clinic coordinator here. Chris Marchand, program coordinator.
Jordan Friend, Evan.
Okay, so could we go to Pyramid Lake first?
Did you say me first?
Yes.
Can you hear me now?
Yes.
Judy Thomas, practitioner, and I'm waiting for my couple of my colleagues. They're running late, of course.
Okay.
But good to be here.
And who's with you?
Good morning, Alan Rendell, the IT. So.
Okay. Nice
How
to
are you
see you.
doing?
Okay, can we go to Carson City, to Nevada Health Centers?
Yes, hello, good morning. This is Ali Shaheen from Nevada Health Centers here in Carson City.
Nice to see you again.
Nice seeing you.
Okay, at Mount Grant.
Hi, this is Toby Morris. I'm the nurse practitioner.
Great, nice to see you. Jan, do you want to introduce yourself?
Hello, I'm Jan Boyer. I'm diabetes clinical nurse specialist in Elko, part-time at Southern Bands Health Center, certified diabetes educator, and now an integrative health coach, which we're really excited about. So
That's great.
good to be here this morning.
Okay, you want to say hello?
I'm Peg Nicholson, Nevada Health Centers, the NP Jackpot Clinic.
Great. Penny at Pershing?
Penny Haas, nurse practitioner out in Lovelock.
Lovelock. Wonderful, thank you. And Dr. Van Gilder?
Hi, I'm Dr. Van Gilder. I work out here in Lovelock as well.
Great. Krista?
Hi, I'm Krista Secord, nurse practitioner in Elko.
Great. Well, nice to see everybody. We surprisingly had no cases submitted, which does not mean by any stretch of the imagination that we're not happy to talk about cases if there's anything that you want to discuss. We also, on the spur of the moment, or at least on the spur of a moment 2 weeks ago, decided that we really should talk about a new category of medications, or at least a relatively new category, the SGLT-2 inhibitors. A category of medication that I think is here to stay and worthy of review, because I think that there are some specific issues related to the use of those medicines that we wanted to be aware of. I think they do have clinical utility, but there are, as with most meds, it's a mixed blessing. So we thought it was worth a review, and I asked Veronica to put together a little review of that topic. When I was in training, my boss said to me that the first year that a drug comes out, he wouldn't give it to his worst enemy. And in the second year, he might give it to his worst enemy. And in the first 5 years, he wouldn't give it to his dog. And then after 5 years, he would consider using a new medication. And I think, that was in the days when we had like 3 drugs. We had digoxin, Lasix, and quinidine. Those were about the 3 drugs that we ever had to use. So now we have a much broader set of pharmaceuticals to use. But I think the caution is still warranted. Maybe it's a bit extreme, but I do think we have to be somewhat careful. It's unusual for us to have new meds that are absolute game changers that everybody wants to jump on board with. I think metformin was one. I think atorvastatin was another. the first of the monoclonal antibody therapies, Gleevec, when that became available in about 2000, was an obvious game changer. But otherwise, most of our new drugs are sort of have incremental benefit. So I think we just have to be cautious. And this category of drugs, I think they have potency. They're in general pretty non-toxic, but there are some tricky little things about them that I thought we should talk about. So having said that, we can dive into that but again, if anybody has a case they want to present first, we're happy to do that. Okay. All right, seeing no hands raised, we will, Veronica, it's on you.
All right, we will move forward. So I'm going to talk about SGLT-2 inhibitors and some of the benefits beyond lowering A1C, and then we'll get into some of those caveats about when you would not want to give the drug. That being said, these drugs first came, which one is?
To the right, this one, that should be.
Not so much.
It's too long.
Okay, right. So thinking about what Dr. Clash said about the first 5 years, you don't want to give these to your dog. Well, they're not ready for the dog yet because the first one was approved by the FDA in 2013, so we got a little ways to go. So I think I have it now. So as you know, when we talk about type 2 diabetes, we talk about the ominous octet, the various organs that are involved in causing problems with hyperglycemia. So the organ that we're going to talk about today is the kidney, and the thing that happens with the kidney is increased glucose reabsorption leading to the hyperglycemia. So the class of drugs that have been developed to address that are the SGLT-2 inhibitors, which will increase renal glucose excretion. So when we talk about the sodium glucose cotransporter 2, we're looking at a drug that blocks the reabsorption of glucose by the kidneys. It will increase glucose excretion, thereby lowering the glucose concentration. And primary use is in patients with type 2 diabetes. So when you look at glucose excretion or the renal threshold, if you go to the far right of the slide, you'll see that for people who have type 2 diabetes, that renal threshold has been dramatically increased. Normal renal threshold is about 180 milligrams per deciliter. In folks with type 2 diabetes, because though the SGLT-2 thank you. The receptor has not been saturated. It reaches saturation at about 250. So people who have type 2 diabetes have a glucose excretion once their blood sugars reach 240. The role of the SGLT2s is to inhibit those cotransporters and decrease that threshold to about 80 milligrams per deciliter. So when you look at normal glucose excretion or reabsorption, when you look at the proximal tubules, you see that 90% of the glucose is reabsorbed in the proximal tubules by the SGLT2s. And then the other 10% is reabsorbed by the SGLT1s and the distal proximal tubule, leading to no glucose excretion in people with type 2 diabetes, primarily if those glucoses are less than 240. When you add the SGLT2 inhibitors, what you will see is in that proximal tubule, you're going to inhibit that reabsorption. And so once you reduce the reabsorption, you're going to end up with increased glucose excretion. So this particular slide is talking about all of the wonderful drugs that are currently in the trial states. And I brought this up because after the situation in 2008 when Avandia was reported to cause adverse cardiovascular events, the FDA required that anybody who was producing a new drug had to have the drugs go through a trial period to determine if there were any adverse cardiovascular events. The areas that you see circled there are all of the SGLT-2 inhibitors that are currently gone to trial. The only one that has had its results reported so far is that of the hepatoglycine, and that particular drug, the results came out in 2014. We're still waiting for the Canvas study, the Declare study, the Credence study, all of those to be reported. The Canvas study is probably going to be reported at ACE and ADA in July. So the others, we don't have the results yet. So as I talk about the drugs, what I'm going to talk about a bit is empagliflozin in particular, and then I'll do some generalities. Because one of the things that we wanted to think about in regards to these drugs were some of the things that were going on with them. Were they a class effect? So I'm going to look at it from the standpoint of the empagliflozin, and then we'll kind of circle back around. So when we look at empagliflozin, we know that it's a selective inhibitor of the sodium glucose transportation. It's going to reduce the glucose by reducing renal glucose absorption and increasing urinary glucose excretion. It can be given as mono or add-on therapy according to the drug company, but when you look at the guidelines that are published, it really should be given as an add-on therapy as opposed to a monotherapy. Class effect is indeed a reduction in A1C, weight loss, and usually reduction in blood pressure. For empagliflozin, we know that it causes reduction in blood pressure without an increase in heart rate, which is not necessarily true for the other drugs. So I'm going to go the long way around, the short way around.
I think the long way around.
The long way around? Okay. All right, so we'll go the long way around. So when we look at empagliflozin, and we wanted to look at the cardiovascular risk associated with the drug. And so when we look at it, we saw that it decreases blood pressure, it decreases albuminuria, it decreases oxidative stress, certainly a decrease in weight, decreases visceral adiposity, as well as oxidative stress, and also decreases the triglycerides. However, it will increase the LDL as well as the HDL, but overall decrease in the triglycerides. So in the empagliflozin study, it's important to look at this because when we think about using drugs, one of the things that was a concern that we discussed at one of the meetings I was at was the fact that as a cardiologist, this will be a great drug. You've got a patient with type 2 diabetes, you're a cardiologist, here we go. Let's toss this drug on them and we're going to get some wonderful effects from it, some wonderful benefits from it. But in this particular drug, what we looked at were patients who had A1Cs between 7 and 10%. They were greater than or equal to 18 years of age. Their BMIs were substantial, about 45. GFR, of course, we don't want to give this to patients with a GFR less than 30, so GFRs are greater than 30. But the thing of interest here is these patients had established cardiovascular disease. And I point that out because in the other studies that are coming forward, the patients did not have cardiovascular disease and they were older patients. So when they looked at these drugs, what they were trying to see is what the 3-point MACE was. So they were looking at cardiovascular death, non-fatal MI, and non-fatal stroke. Patients were randomized 1 to 1 to 1. So a third of them got empagliflozin 10 milligrams, a third got 25 milligrams, added to standard of care. So if they were already on drugs, they stayed on those drugs, and this was added to what they were already on. And then the other third got placebo. So in this patient population, as you can see, it was primarily white males that were enrolled in the study. The patients had diabetes for greater than 10 years, about 60% of them had diabetes for greater than 10 years, and 99% of them had some cardiovascular risk factor. Coronary artery disease, prior MI, they had a prior stroke, heart failure, and all of them had eGFRs that were acceptable.
There's a question here.
Oh, sorry.
Jan.
Yes.
What is the brand name of empagliflozin?
I'm sorry. It's Jardiance. So I don't know if you all heard the question. The question was, what's the brand name of padagliflozin? And that's Jardiance. So in looking at this, for the patients, the time since diagnosis, most of them were greater than 5 years since their diagnosis. And when you look at their add-on therapies, metformin, our go-to drugs, about greater than 70% of these patients were already on metformin, 42% on sulfonylureas, about 4% on TZDs, and 48% of them were on insulin. So this was added on to those particular therapies. So when we look at the effects over time, so what they were looking to see was if there was any benefit to starting the patients on empagliflozin. And as you can see, at about 4 months, you see a separation in the endpoints. And as time went on, what they saw was a 14% decrease in the primary outcomes. So there was a 14% decrease in adverse cardiovascular events in the patients that were receiving empagliflozin as opposed to those that were on placebo. And in order to see if it were an effect, a dose-related response, what you can see by the purple and the blue lines, there was not so much a dose-related response. So the folks that received 10 milligrams compared to those that received 25 milligrams had about equal responses. This I thought was very interesting. When you look at cardiovascular death, there was almost an immediate separation. And you can see that there was a 36% reduction in cardiovascular events starting at about a month, 2 months in. So there were some decided benefits from these patients being placed on the empagliflozin. Cardiovascular death, again, you can see that there was indeed benefit to those that were on empagliflozin as opposed to placebo. Heart failure, similar results. Skip that one. And all-cause mortality. So the benefits to the patients that were on empagliflozin had about a 32% reduction in all-cause mortality. Glycemic control, the patients who were on empagliflozin had about a 0.7 to 0.8 reduction in their A1C compared to those that were on empagliflozin. So when we look at A1C reduction, it's not the most powerful drug that is available on the market, but there's some decided benefit as far as A1C reduction. So the conclusion that we're come to with this particular drug is that there was definitely lower rates of adverse cardiovascular events. So there was a significant reduction in cardiovascular death with no significant difference in the risk of MI or stroke. There was a there was a decrease in death from any cause, also a decrease in hospitalization for heart failure. The overall for the 3-point MACE, so looking at the adverse cardiovascular events, there was a 14% reduction in those adverse outcomes. So for the patients who received empagliflozin, what they found was the risk of cardiovascular death and all-cause mortality, death by all-cause mortality, say the words, just read the screen. Reduce the risk of cardiovascular death and all-cause down by 32%. So when they looked at the safety of the drug. There was no significant difference observed between the folks that were on empagliflozin as opposed to those folks that were on placebo when they looked at adverse events and severe adverse events. And certainly there was more hypoglycemic events for those patients who were on empagliflozin, but there were no events that led to hypoglycemic events that led to death. And then they looked at urosepsis. So the overall rates of UTIs, complicated UTIs, pyelonephritis were similar in both of the groups, both those on placebo as well as those that were receiving the empatigoflosin. So now to circle back around more to the generalities with the drugs. This is in relationship to Invokana in particular. So we know with the empatigoflosin, there was a 0.7 to 0.8% reduction in A1C. For Invokana, which is canagliflozin, canagliflozin had a lowering of A1C of about 8% for the 100 milligram dose and a little over 1% for those on the 300 milligram dose. So for any of the drugs in that particular class, and I have a slide that goes into it in detail, but the main benefits, the class effects that you see are certainly weight loss and with a low risk of hypoglycemia. The things to think about with these patients, and I'll give you some ideas of patients that I have seen, but when you look at primarily myconic infections in females and urinary tract infections. So a couple of the patients that I've seen have had long-standing histories of infections, and they come in and they've been placed on one of these drugs and never evaluated for the rip roaring infections that they have, because sometimes it's embarrassing for patients to bring that up. So if they don't bring it up and you don't ask the question, this can go on for prolonged periods of time. So a couple of the ladies in particular that I have seen have had just rip-roaring infections. I've also had one that developed a skin infection. She had multiple skin folds and ended up with a fungal or mycotic infection that once taken off of the SGLT-2, this did resolve. But that is something to think about in this patient population, whether they have a history of the infections, and being sure that if you do start them on the drug, to ask them about infections. So you do have to be cautious in the use of these drugs with patients who are elderly, because one of the things that when the drug rep comes by and talks to you about, they don't talk about the fact that the patient needs to be well hydrated. So that patient who doesn't take the time to drink, I'm not really interested in water, or, I'm too busy during the course of the day. They work outside in the sun, they're sweating profusely, they don't get the fluids in. These folks can end up with a euglycemic diabetic ketoacidosis. I had one of my very first patients that I started on the drug ended up with euglycemic ketoacidosis because they don't mount the usual response. So they're not necessarily having elevated blood sugars. This patient's blood sugar never got over 200. So he had no idea that he was in trouble, except for he was nauseated and vomiting and had belly pain. So when he went to the emergency room, he had a significant gap and ended up in the ICU on an insulin drip. So you really have to be cautious in the patient population that you look at using this particular drug. The other thing to think about is in folks with renal impairment. And one of the things that was talked about is in patients who are started on the drug, one of the questions that I've been asked multiple times, is it good for my kidneys to put out this much sugar, to filter this much sugar? So initially, when it was talked about, you do see a decrease in the GFR initially, and then after about 3 months, it will bump up and it will show a slight improvement. The usual effects, there has not been adverse effects as far as patients going into chronic renal failure from the drug, but you do have to be selective in who you use those drugs in. They are not for people with ketoacidosis, those on dialysis, those in renal failure. So I'm just going to walk you through a case of a patient that I used SGLT-2 inhibitor on. And this was a gentleman who, with a 14-year history of type 2 diabetes, he came into I saw him multiple times, and each time he came into the clinic, he had gained, every 3 to 4 months, he had gained between 5 and 10 pounds at each visit. So we know that insulin therapy does cause some weight gain, and this guy was frustrated. So past medical history, aortic stenosis, murmur, hypertension, dyslipidemia, he's a smoker, blood pressure 160/89, weight 264 pounds with BMI 36. His A1C, he's in a ballpark at 7.6%. Currently on Lantus, 50 units, Apidra 15 units with meals, Tradenta, metformin, a gram twice a day. And his biggest concern was that he was continuing to gain weight, and his insulin doses, yes, I had increased them at every visit. So he was very frustrated by that. So in looking at this gentleman, I decided, let's try it. Let's see if it really works. So I did start him on Jardiance, and I started at 10 milligrams. It did not get me what I wanted. After a month, I bumped him to 25 milligrams. So he returns in 4 months. Granted, his A1C is rock solid, the same at 7.6. His weight hasn't changed, but that's a boon for him because he hasn't gained the 5 to 10 pounds that he's been gaining every 3 to 4 months. His blood pressure is down to 102/68 with a pulse of 80. This gentleman was extremely happy, and so was I, because I did not increase his insulin doses at that point in time. So he certainly has been encouraged to modify his diet, which he had not done and is having some difficulty with that. But the benefit that I saw for him was his blood pressure improved. I did not have to add another blood pressure medication. His A1C was stable. I'd like to get a little bit lower, but his A1C was stable, and he had not gained weight. So that's my case. So I've got a couple of cases, but I won't go through all of them. So when we look at the drugs in this class, the canagliflozin, which is the Invokana, the dapagliflozin, which is Farxiga, and the padagliflozin, which is the Jardiance. As I already said, they're not ready to give to your dog yet, but if you do consider giving the drugs in monotherapy, the A1C lowering for monotherapy, as you can see, runs between 7 and 8%. In combination, I'm sorry, 0.7. Ooh, that would be awesome.
Yeah, that would be amazing.
Nobody's taping this. In combination, it doesn't get much better than that 0.7 or 0.8%. The frequency of dosing is once a day. And one of the things that you do want to tell your patients, take the drug in the morning. So I usually tell them take it in the morning with their first meal, and be sure to drink their fluid throughout the day. So in this particular study, they looked at the creatinine clearance, but we're looking at their GFRs. If that GFR is less than 30, this drug is definitely contraindicated. Less than 45, it is used with caution. So as I stated, when you look at the ADA guidelines, it is recommended as, not recommended as monotherapy. It is recommended as add-on therapy, either as dual therapy or triple therapy. And my take-home message for you is this. When we are treating patients with type 2 diabetes, there are a lot of things to think about. We have a variety of drugs in our arsenal at this point. So you really have to think about what you're treating. And when you look at your patients, there's some of the things to think about. Certainly, do they have coronary artery disease, heart failure, renal or liver disease, dementia? Those kinds of things are definitely going to impact what drugs you decide to use. And the treatment plan does need to be individualized for the patients, taking into account age, comorbidities, and cost. So that's my high level overview of the drugs. Questions?
Yes, hello, this is Ali Shane from Carson City. I have a question. First of all, thank you very much for the presentation. I really enjoyed it. It was very, very nice. And so my question is, with the data you were sharing with the benefits of the Jardiance with a cardiovascular outcome, so because of this data, do you tend to go to Jardiance as your first line SGLT-2, or do you think it's a class effect and you really, Jardiance and Invokana, Farxiga, and prescribe them the same?
So when I look at patients, one of the things that we're talking about with diabetes, our primary thing is we're trying to prevent adverse cardiovascular events along with lowering A1C and getting them better all control. So the thing that we don't know is if it's a class effect. The only thing that can be said for sure for class effect is it's going to lower A1C, cause some weight reduction, and likely cause a lowering of blood pressure. The other decrease in MIs and strokes, we don't know. That has not been shown to be a class effect, as I said with which trial? The trial is going to be published in July. The cadence study. So we'll find out more information in July, and then the DECLARE study doesn't end until 2019. So we don't know that this is indeed a class effect.
And let me just add this. So when these cardiovascular outcome studies are done, as they were dictated by FDA after the Avandia nightmare, remember, these studies are powered for non-inferiority, right? They just want to prove that the goal of the studies is to prove that these drugs do not increase the risk of cardiovascular outcomes. So they're not specifically designed to test whether they're better. So a little bit you have to say, all right, these data are really interesting and intriguing, but I'm not sure they prove benefit. I think they're suggestive. So to me, I generally believe that drugs that act via the same pathway, the outcomes are generally going to be class effect. So to me, the biggest determinant might be what's available on the patient's formulary. And while I might prefer the drug for which we have some, better evidence, I would probably be willing to accept a drug that the patient could actually get based on formulary if it were of the same class. So I would kind of say, well, if I could give that drug, I would, but if I can't give that drug and I can give essentially a lookalike drug, because that's what our formulary will allow, I'd probably be willing to accept that.
Thank you.
So in that case, in the case you presented, the patient was on a DPP-4 inhibitor,
yes,
right? And gaining weight. So how come you didn't say, let's swap out the DPP, and he's already injecting, right? So why not swap out the DPP-4 and give a GLP-1 analog?
So part of the reason is patient didn't want to do an additional injection.
Okay, there you go. I figured there was a good reason.
That's where I was headed.
Okay.
That's where I was headed. So that's a great question. So initially in patients like that who have concerns about weight gain and folks who are on insulin who we know insulin's going to cause some weight gain, I will go with a GLP-1 if I can convince that patient to do an additional injection. Part of the struggle with that is one, taking an additional injection, and if patients who enjoy their food hear nausea, potential nausea that can last for a little while until you get adapted, they are not interested in that. And it's like, well, you're gonna vomit and it will go away. It's just you're queasy.
And you'll eat less and you'll
lose weight. But the additional injection and nausea, there's something about nausea. So if I could not say that, but I don't feel comfortable not saying it, because then they call you and it's bad. So that was the reason I didn't go with the GLP-1, because I really would have liked to do the GLP-1.
It's funny, we are so rich in therapeutic options at this point. There are so many drugs that are effective and in general quite safe. You can see from one of the early slides was that when Jardiance was added on, about 40% of patients were on sulfonylureas. And if we were to say, what should be the general direction? Sulfonylureas are dirt cheap. And for most patients, they're reasonably safe. But, we're still stuck with the fact that cardiovascular outcomes are probably worse, right? I mean, we've never shown that they were not worse, right? It's a little confusing, but they tend to, we're still, that we kind of know that. And if there's a general trend or a direction I think we should be moving, it's to reduce use of sulfonylureas. Look to see what therapeutic options we have, especially in patients who aren't doing all that well because of weight gain, because of hypoglycemia risk, and because of this, sticky little issue of cardiovascular outcomes. We should be looking at these newer agents. And again, the reason that I thought we should talk about this was this intriguing bit of early evidence that maybe there is the opportunity to improve cardiovascular outcomes with this category of medications. So I think it's a great time, and as we reassess our patient's status and as we keep looking for better control, better safety, better cardiovascular outcomes, we should be factoring in these newer agents and, again, looking to get rid of sulfonylureas where we can, especially in the elderly. Remember, in the elderly, sulfonylureas are on our list of Beer's watch-out drugs, so especially glyburide. So great opportunities, I think, to improve care, as long as we're somewhat careful about some of the issues that Veronica mentioned.
Dr. Klass, this is Jan. What were the three things due to hypoglycemia, due to cardiovascular, and what was the third one that you... The weight gain. Thank you. Okay. And I have another question as well for Veronica. And I'm glad you asked that one because we've been trying the GLP, I think partly because of our discussions here on Project ECHO. We've been trying the Trulicity more, and it's now on our formulary at the clinic.
That's great.
The good thing about it is it's only once a week.
Mm-hmm.
So that does help when people are concerned about additional injections, and it's just such an easy thing to use.
Yeah.
But I wanted to ask if when we finished talking about this case in terms of the SGLT-2s, I was interested in Veronica's mention of the euglycemic ketoacidosis. And I think that it just kind of hit me because I had a call from a husband who was concerned about it was a hospitalization due to nausea, vomiting. I don't know all the details yet, but apparently she was in the range of normal blood sugar. So I thought, that means it couldn't have been ketoacidosis. But could you talk a little bit about the physiology of that?
Can I talk about the physiology from the standpoint of the fact that, so the glucose is not going to be elevated in the blood because they've been kind of excreting the glucose. So you've got not necessarily euglycemic, but when we think about patients going into diabetic ketoacidosis, we are looking at folks whose glucoses have gotten up to pretty good. For most of the younger people that I see, glucose is greater than 300, 350. I have them test ketones because they're starting to get into a dangerous realm. Well, if you're on an SGLT-2 inhibitor, you're not going to get that glucose up into the 300, 350 range.
Okay.
So their symptoms, they're going to likely have symptoms, but they're not going to have that elevated glucose because it's come out in the urine.
Similar to the scenario in pregnancy, when the renal threshold for glucose goes down, right? We know that pregnant women have glycosuria at lower blood sugars than non-pregnant women, and then alcohol users. So those are two scenarios where we see DKA occurring with blood sugars that often are not appreciably elevated, and it often progresses pretty substantially because our usual warning signs have not, the bells haven't gone off at the usual levels.
Okay, so otherwise, if they're not pregnant or alcohol users or on these SGLT2 T's, so is there any likelihood that somebody that's dehydrated for other reasons could go into ketoacidosis at normal blood sugars? I mean, I'm just trying to think, is there any other time when you could have ketoacidosis without? I can't think of it because you would be, if you have enough glucose, right, you're going to be not going to be burning fat and muscle, so you wouldn't have ketones. So do you understand my question? Is there any other time when you'd have euglycemic ketoacidosis besides those situations?
I don't, not that I'm aware of.
Okay.
You know,
Yeah,
except
that's what I was.
I can imagine an extraordinary circumstance of somebody who is septic, for example, and who has been starving, and somebody with intrinsically normal renal function, so it could have been glycosuric. Conceivably, they could end up in ketoacidosis with not substantially elevated blood sugars. But I think there are enough scenarios now where we need to be at least alert to the possibility that even that DKA can be occurring in patients without marked hyperglycemia. So it's just a new sort of category.
So it was mentioned that if people's blood sugars are starting to get above 350, maybe start thinking about testing for ketones. If somebody is on one of these medications, do you encourage that they start testing for ketones at 200, or is there any discussion about that? I'm just thinking of one gentleman myself.
I have not had that conversation. The thing that I ask them to be in tune to is how they are feeling.
Yeah.
So usually when people end up heading toward ketoacidosis, the things that they will complain about, oh, I'm so nauseous and my belly hurts, I just don't feel good. Those are the things I ask them to kind of be more in tune to.
Okay.
I have not, other than the very first gentleman that I started on the drug, and that's what you get for going before 5 years. I have not had anybody else that has had.
Okay. And is there any specific recommendations that we have for them about hydration? I mean, of course, general recommendations, but is there a certain amount or of water per day? I mean, anything like that, because I haven't seen anything, but.
So I don't usually recommend drinking beyond, so that people say, oh, you need so many ounces per, body weight, a pound or whatever. I don't go beyond that.
Okay.
Because the one time I had one of my colleagues do that, the person ended up dropping out their sodium.
Yeah.
So you do not want to tell people to overdrink, because then they're going to end up in trouble the other way.
Right.
So as long as I do a fairly good assessment, I think, prior to starting anybody on the drug, what are you eating, what are you drinking, and I walk through the list. Okay. If it is somebody working outside in the sunshine and climbing poles and digging ditches, I'm not even offering you the drug.
There you go. And I think that all of the cautions that you listed in that slide, or many of them, were conditions in which maintenance of body water was challenged, right? Patients with hypopituitarism, patients with adrenal insufficiency, anything that would set the patient up for another cause of dehydration, is a warning for a drug that causes dehydration. The remarkable thing about this, which I don't frankly understand, is lowering, and I don't think anybody understands this, is the lowering of blood pressure without a reflex tachycardia, right? You would think if these drugs are perhaps lowering blood pressure because they're causing dehydration, right? Because you are flushing, you have glycosuria, you're losing water with that glucose, you would think you would be volume depleted and there would be a reflex tachycardia. So the fact that doesn't happen suggests that the blood pressure lowering mechanism is something different. And maybe it's got to do with reduction in arterial stiffness. So the physiology of these drugs is pretty interesting, and I think that they have a future. And one of the things that's happening is that, remember, these are SGLT-2 inhibitors. So since they are SGLT-2, it leads one to think there must be an SGLT-1, right? And there are SGLT-1 receptors as well, and they're in the gut. And the gut receptors facilitate absorption of glucose from the intestine. And one of the new areas, some of the drugs coming down the pike, I would say over the next 3 to 5 years, are going to be combination SGLT1 and 2 inhibitors. So they'll both block gut glucose absorption and facilitate glucose excretion. So they may be really, really interesting and potent meds. So I think that we're going to be hearing lots more about them. So,
Judy, did you have a question? Judy and Pyramid, did you have a question? Weren't sure if you were trying to unmute yourself or not.
No. I think Krista did, though, perhaps.
I do. It's one of the things that I'm facing, and maybe many others are too. People who never used to have deductibles now have big deductibles, and they were on really good meds, are now bringing in their formularies and want to be on tier 1 meds, which is the Walmart $4 list or something pretty close to it. But one of the meds that is on most tier 1s that we don't use very much that I'm thinking about using is Actos. Just because it's affordable or it's on the tier 1. Do you use much of that? And can you tell me a little bit about why and when you would or wouldn't use that?
So pioglitazone, Actos, is a fine drug. It's a potent glucose lowering drug, with an A1C lowering of about 1%. It's gotten a bit of a bad rap, right? In a sense, it's a very good glucose sensitizer. It has specific efficacy in patients with fatty liver. It's the only medication that actually has demonstrated to improve patients with fatty liver disease. So that's a huge issue. But here are the downsides to it. This is probably true that the risk of bladder tumor development is increased. Now, not a huge thing, but it's not been refuted. It's been suspected. It causes weight gain. Now, you might argue this is not visceral fat. This is peripheral fat. So from a health standpoint, maybe not as detrimental, but patients are not that happy with weight gain. And it is a potent weight gainer. Causes loss of bone density. Okay, so an issue, especially in older women, and it causes fluid retention. And again, it's a potent fluid retainer, so in anybody with any degree of heart failure, it's of concern. So, having said that, it's a perfectly fine drug, and for patients who can't tolerate metformin, for example, you're out of luck, right? What other insulin sensitizer do you have available? It's the only other one. So it does have, I think it does have a place, but I think we use it very, very selectively because of the downsides, none of which are fatal, but all of which are somewhat problematic. And I never use it there are 3 doses, right? Those doses are
15, 30, 45.
Right, so you can give either 15, 30, or 45, and this is what I do, and I'm not telling you to do this, but this is how I use this drug. I never use the 45 milligram dose because of weight gain and fluid retention. I never use the 15 milligram dose because I said for that degree of efficacy, what am I bothering for? So I always use the 30 milligram dose. It's not a printed best practice, but I will tell you that's class's best practice because that's what makes sense to me. I don't know.
I agree with that 100%. I don't even touch a 15, and the only reason I would go to a 45 is if that gentleman, and it's always a man, who's sitting in front of me says, yeah, I'll go for a higher dose of the drug because, my gut doesn't bother me.
Right.
A woman never says that. Never. So I'll use 45 sometimes in a gentleman, but I start 30.
Yeah. So again, I think that we probably underutilize it because of concerns and there's still kind of a carryover effect from the cardiovascular concerns. With pioglitazone, they're not a concern. But again, I think that I'm not a proponent because I don't want to shift the focus from the drug we should be using, which is metformin. And we should be forcing metformin as much as possible. And only when that is an absolute failure should we look to the glutazones, I think.
And the only other thing in regards to the bladder cancer, if you have a patient that's a smoker, those are the folks who are at increased risk for the bladder cancer. So if you're using it, just think about that.
Thank you.
Okay. Any other questions at all? Yes, Peg.
I was just thinking what would be very helpful for me would be if we could do a session where we went through all the additional classes of diabetic drugs, comparing them. Because right now I'm pretty well limiting my patients to metformin, going from there to Atlantis or Toujeo. I avoid sulfonylureas completely, but I feel like there are other things out there. I'm a little worried about formularies with the SGLT-2 inhibitors. I'll have to look into that. But would it be worth just doing a really elementary, here are the options, here are why we like this option, the add-on options is what I'm talking about.
Well, I think what we'll do, Peg, I mean, we can loop back to that maybe in the fall, but we will post, I think we probably posted treatment guidelines, you know, the templates that have been published. The recent one from Annals of Internal Medicine, I think, is very straightforward, and we can post that on the website.
Send them to her.
Okay. Yeah, so I think that's terrific.
That would be great.
One of the things that I've been thinking about, since we have a couple of minutes, is whether there would be interest for you all to be learning about, in some detail, the use of continuous glucose monitoring. And I thought I might ask Veronica to maybe do you know, sort of an every 2-week session to try to build competency for you, or help you build competency in initiating continuous glucose monitoring in your patients. Because I think it's ready for prime time. And I think that it's something that you all could be doing and shouldn't be gun shy about. So, and I think we're pretty well positioned to do some training. So if there were interest in that, maybe that would be kind of a summertime project for us. All right, so we can talk about the available modalities, we can talk about strategies for initiating, we can even talk about how you can get paid for evaluating this information, and because I think there's actually enormous value to doing this. I think patients by and large like it a lot, and I think it's you know, another good direction for us. Now, in 2 weeks, Dr. Arshad Kanani is going to be doing a review of diabetic retinopathy. He's got a new partner, Dr. Freeman, who I think is going to join him. So we'll do a diabetic retinopathy review, and I'm sure they'll have some great pictures. And nobody has any other questions? We'll see you in a couple of weeks. Okay, so long.
So much.